Okay, why don't we get started? Good morning. My name is Ann Griner. I'm President and CEO of the Primary Care Collaborative, and I am so excited to welcome you all to PCC's first Lunch and Learn of 2022. This is the fourth Lunch and Learn that we've done, and we will have 3 more this year. So I hope that you'll come back and join us. If this is your first time coming to a PCC Lunch and Learn, please take advantage of the webinar on our homepage to learn more about this project. And if you haven't yet seen the curated list of very important primary care research articles that our research dissemination work group helped to curate, I invite you to check that out. Let me turn this over to Noah, who's going to give you a quick view of that list, and then we'll get started with our papers.
All right, good morning, everyone. So yeah, as part of PCC's PCORI project to disseminate primary care research to policymakers and practice leaders, we have officially released a list of seminal primary care research articles on our website, which was curated by our research dissemination work group. And I will briefly run through those slides. So you can go to our main page, and it's under the Resources tab, Research, and then click on the Hub for Current Research. This will bring you to the curated list of 24 articles. And you can also use the link provided in the slide and in the chat. So you can filter the articles by the 7 shared principles of primary care. And if you click on a shared principle icon, it will bring you to another page where you can read more about that principle. You can also filter the articles by clinical articles and health services research articles. When you click on an individual article, it will bring you to a page that has the article abstract, a link to the original publication, and a recording and discussion summary if it was featured on a previous Lunch and Learn. Finally, in the About the Project page, you can read more about the project, the research dissemination work group leadership, and access the dissemination resources that accompany the articles. So yeah, we hope that you find this page useful, and please share it with your colleagues. So next, I would like to pass it on to Dr. Donkwa Mullen to introduce our first article and speakers.
Thank you, terrific. I am also delighted to be here and to moderate this panel. We have our distinguished speakers who are co-authors on this first article, Effect of Community Health Worker Support on Clinical Outcomes of Low-Income Patients across primary care facilities. So I'm going to introduce, and this is really of interest to me. We know community health workers are really critical to improving not just population health, but individual health. And there's been a number of studies. So really delighted to learn more and, about this. And so we have Dr. David Grande. He's an associate professor of medicine at the University of Pennsylvania School of Medicine and director of the policy at the Leonard Davis Institute of Health Economics. His research focuses on healthcare for vulnerable populations with an emphasis on identifying and overcoming barriers to care. He also studies ethical issues related to marketing in healthcare and digital health information privacy. He is going to be co-presenting with Ms. Ashlee Harris, who is a community health worker at the Penn Center for Community Health Workers. And throughout her 4 years at the center, she has provided social and emotional support to many disadvantaged patients in the Philadelphia region, including individuals with sickle cell disease. Ms. Harris also advocated for a patient to develop and facilitate her own sickle cell support groups. And this group educates, supports, empowers patients and their families. And so inspiring work that you're doing, Ms. Harris, and glad to be learning more from the two of you. So I'll hand it over to David. Take it away.
Great. Well, thanks so much for that introduction. And my job is to try to get through discussing this paper as quickly as possible so you get to hear from who you probably really want to hear from, which is Ashlee, because she can share a lot more of her experiences on the ground in this program. But again, I want to thank you all for the opportunity to present this work. This is a group of people on this call that's doing very important work in primary care. So it's certainly a privilege to have this opportunity to have this conversation. This is work that it absolutely has been a team effort along the way. Ashlee Kangovi has been the leader of our team for a good number of years now. And this work has been supported by NIH as well as PCORI. So let me see the next slide. So, again, this is a group that undoubtedly knows the extraordinary importance of the social environment on health. The conditions in which we live and work have powerful influences on health. And over the past decade, I think we would all agree there's been very strong interest among healthcare organizations to intervene on unmet social needs. But the real challenge is facing a lot of health system is identifying effective, scalable strategies to do so. Next slide. So our work, as you can tell, has focused very much on community health worker-led interventions. CHWs have been, over very long history, the cornerstone of many existing social interventions. And they are trusted lay people who live within communities they serve and are well positioned to address social issues like hunger, joblessness, and so many other social influences on health. But unfortunately, many CHW programs in the past at times have been disease specific, at times have been somewhat unstructured and have often lacked rigorous evaluation. And so that is what we set out to do in designing and evaluating the impact program that was developed here at Penn. Next slide. So over the past decade, Ashlee Kangovi has led our team in developing and refining what we call the impact community health worker model. And when we talk about impact, we often focus on three key elements. The first is that it's a program that is intended to be patient-centered, so not disease-specific. The focus is really driven by patient goals and needs. And so when the program starts, community health workers often begin their engagement with patients by asking them what they need to improve their health, and then offer hands-on tailored support based on what they hear and learn from patients. The second is that it's standardized. So very high fidelity processes related to hiring, training, supervision, and really trying to have standardized procedures in place and field manuals that guide the work of our community health workers. And then lastly, that it's evidence-based. And so again, we've tried to use a lot of strong research design and rigor along the way in designing this program, evaluating it, and refining it. Next slide. So our work originally started with designing and testing a community health worker program following hospitalization. And that's how we initially had designed the program. And that's that first article that you see mentioned there. And then we eventually adapted that model from a multi-week intervention when patients are leaving in the hospital, which we still have that program, but developed a companion program that was focused on the ambulatory care setting with a much more longitudinal focused intervention among patients who have multiple chronic diseases. In these two trials that were published previously, we found improvements in both of these interventions on dimensions such as mental health and quality of care that we saw. And then the ambulatory study impacts on measures of chronic diseases. Can I see the next slide? So the study we're talking about today built on those two and is a multi-center randomized controlled trial conducted in 3 settings, all ambulatory settings. So the first was at a VA hospital. The second was based at a community health center, at a federally qualified health center. And the third was a primary care practice based at an academic medical center. And what we set out to do was determine whether 6 months of CHW support could lead to improved outcomes. And I'll talk more about the details. Next slide. So the participants, in terms of inclusion criteria for the trial that we ran, they needed to be uninsured or publicly insured, residents of a high poverty region in Philadelphia, which was generally located in pretty close proximity to where these practices were located. And they needed to have at least 2 of these chronic diseases that you see on the slide: hypertension, diabetes, obesity, and tobacco dependence, and at least one of those in poor control. The outcomes were measured at 6 and 9 months. The intervention itself was 6 months, but we were interested in having follow-up after the intervention had stopped. We measured self-rated physical health, mental health, chronic disease control, patient activation, quality of care, and all-cause hospitalizations. But I want to tell you a little bit more about the intervention in the arms of the RCT. So participants were randomized to one of 2 arms. The first arm, which was more on the usual care variety, was goal setting alone. So patients who had these chronic conditions would identify a particular chronic condition they wanted to work on and a specific goal they wanted to reach. And in the usual care arm, they generally did that with the support of the usual clinical care team and the patient's provider in the office. However, in the intervention arm, the community health worker arm, a community health worker was assigned to meet with the patient and work alongside them to develop a tailored approach to supporting the patient. However, instead of simply focusing on the clinical goal, the CHWs started their work with patients by asking, what do you think you will need to improve your health? They then develop goals and plans with the patient that are often far upstream, actually, from the clinical goal. So for example, if joblessness was the most important issue impacting health and blood pressure control, rather than focusing on taking pills, the focus was really on trying to get upstream to try to address some of the challenges related to joblessness. Next slide. So the 2 study arms were generally pretty similar in all baseline characteristics. So I'll just show you the overall characteristics of the study population here. And you can see, in terms of the patient population, generally overwhelmingly African-American. In terms of household income, relatively low household income, again, based on what you'd expect from the inclusion criteria from the trial. Very high rates of trauma history in the population, and you can see here some of the measures of chronic disease control among the 4 that we focused on. Next slide. So to orient you to the table here, we're looking at differences over that 6 and 9 month period between arms in each of our pre-specified outcomes. So for continuous outcomes, you see difference in differences, and for categorical outcomes, you'll see odds ratios. Both are from longitudinal GEE models that adjust for the site that the patient was at, as well as the chronic disease that they were focused on. As you can see, both arms had relatively similar improvements in physical and mental health. The intervention arm had greater improvements in patient activation and modest improvements in chronic disease control, although these were generally not statistically significant. However, patients in the intervention arm were much more likely to rank the primary care that they were receiving at the highest quality level on the Consumer Assessment of Healthcare Providers and Systems survey. Next slide. But the biggest effects that we observed were around hospital utilization at 6 months. Intervention patients spent 155 days in the hospital in total versus 345 days in the control group, an absolute event rate reduction of 69%. And we saw persistence of this effect at 9 months, again, even though the intervention had been turned off after 6 months. And so there we see 300 hospital days in the intervention group compared to 471 in the control group for, again, a similar reduction. Next slide. A lot of these differences in terms of hospitalization were explained by a shorter average length of stay, lower odds of repeat admissions, including 30-day readmissions among patients who were hospitalized. Next slide. And so just some key takeaways here from our perspective. First, when we talked about the initial adaptation of this intervention from the intervention that had been developed initially in the hospital setting and then adapted to an outpatient setting. Here we then adapted it across these 3 other settings, and we're able to do that in a relatively quick fashion. And that yielded benefits in a relatively short time horizon, and at least on some of our measures, demonstrated a persistence of effect. We saw improvements in patients' perceptions of the healthcare quality they were receiving. We saw large reductions in acute care utilization, and though we did not see significant changes in chronic disease outcomes, we have seen in some of our other studies mental health benefits and some improvements in disease measures. And then through other work, we've also demonstrated a very favorable return on investment for Medicaid payers to invest in this model, generally returning well over $2 for every dollar invested. And so taken together, we believe these findings support the notion that social interventions aren't just an ideal, but a practical tool that healthcare organizations can deploy to improve clinical outcomes. And so with that, I'm going to invite Ashlee Harris, as I mentioned, to the conversation before we take questions. And though I focus again on trial outcomes, I think Ashlee can give you a really strong sense of what this program looks like on the ground and what the program looks like in action, so you can get a better sense of what interventions look like in practice. So thank you.
Thank you, David. Good morning, everybody. So again, my name is Ashlee Harris, and just to give you a little gist of who I am and like what I do, I'm a community health worker now. I was raised in Philadelphia and I still reside here. While living in Philly, I wasn't raised with a silver spoon in my mouth. I was actually raised by a single mother. And my mom, she became disabled as a child because she was hit by a drunk driver. But although she grew up with a disability, she never let that stop her from doing anything. She basically used her experiences to help others, and she instilled that in me as well. So my mom even went on to help write the policies and procedures for the Americans with Disability Act in Philadelphia for housing and employment. But living in the city, you don't have all of the advantages that one should have, but I use those challenges, in my life to help other people, just like my mom. So now I'm working as a community health worker, and basically what I do is I reach out to people who live in the community, and I provide them with support based on who they are and what they need. Most importantly, I do not talk at them. I listen to them. I want to know what it is that they feel that they need. And how I do that is by getting to know them and their life story. So basically, just an example of a patient that I was working with, and just to give you a better insight on, what it looks like on the ground with working with patients. So I met a gentleman by the name of James, we'll call him that. He was referred to me because he was struggling with drug addiction. And people were treating him as if he was a difficult patient, but really they were intimidated by him. But I sat there and I listened to James, and, after getting to know him, I found out that, he was such a sweetheart. I felt like he wouldn't hurt a fly. But as I talked to him more, I see that it was some more deeply rooted trauma. And he was involved in a tragic incident where him and his sister were using, and unfortunately his sister overdosed. James was charged with it and blamed by his family and friends. So dealing with that type of trauma, he never recovered from that guilt, What I did for him was make him feel loved, He wanted to get sober and get on the right track and stuff. So what I did for him once he was about to go into the rehab and stuff, I made him a love package, which included snacks, underclothes, pajamas, which was a big hit. I didn't think pajamas would be that, you know, meaningful to somebody, but to him, it really meant something because he hadn't worn pajamas since he was a kid. So just by me doing the simplest thing is like making him a love package, that made James feel loved again. And he felt like he actually mattered to somebody. Then that helped him to get motivated, you know, to have hope for his own future. I got him enrolled in a literacy program that got him amped up. And then James just took off like he was on his path to recovery. So when I'm working with patients, what I do is I find out what they need and we set up goals together that's realistic to them and what's going on in their life. You have to meet people where they are at, you know? So like working in primary care and doctors, I strongly suggest getting to know the community that you're serving, you know, because I feel like by doing that, you're meeting the people, you know what's going on and you have better outcomes. You know, no one wants to be sick or ill, but you wanted to become a doctor. So I feel like you should take the time to treat everyone with kindness and love. And I think this will help us all, you know. And I hope this gives you a better understanding of who I am and what I do as a CHW. And thank you all for allowing me to talk today.
That's awesome. Thank you so much, Ashlee. So inspiring. I mean, there is no doubt that community health workers as yourself have built that trust, right, with patients, and you have a deep understanding, and especially when you've basically been through, have that live experience, or you have that empathy. I think that's what really is critical in forming that bond. So thank you. There are a few questions that have come in the chat for you and as well as for David. But a quick question which is in the chat is about training certificates. Whether you could speak to that, has there been, and some states offer that, and is this across the board, or how does that work? And it could be for both of you, right?
Yeah, I would actually ask Ashlee if she's feels comfortable answering the question. I think she's more steeped in on the ground training programs that right. The center runs, and so maybe she can take that question. But I will say that, like nationally, we're certainly seeing more of a move toward various forms of certification, whether that be certification of individual community health workers or accreditation of community health worker programs. And so I think that's a direction that the field seems to be heading. But Ashlee, why don't you take the meat of the question?
Yeah, there are certifications. Some states it's mandatory, some aren't. I'm actually on the Pennsylvania certification board for community health workers because you don't want it to get, I feel like CHWs, we're from the community. We have right. empathy, you know, we have lived experience. Everybody can't be a community health worker, you know, and to know exactly what is needed in these certain areas. So that's one of the reasons why I joined, because certification is good, but it's not everything, you know, because it's really about your lived experience. And we don't want to lose sight of that fact, you know, of your lived experience. And then it gets to educational, you know, you need to be a bachelor, have a bachelor's degree or a master's degree to become a CHW. And that's not the case, you know.
Yeah.
You need to have the experience. You need to be there, you know, to know how to help other people. So yeah, there are certifications here in Pennsylvania and other states about to answer your question.
And I'll just say, I see that in the chat, and I know Ashlee just spoke to this, you know, we do have to think about downsides to certification. You it does create barriers to entry. It can, in some sense, create the wrong set of standards in terms of thinking about who can best do this job. On the other hand, we do want to think about some sort of training and achieving some level of standards. So it is a balancing act to make sure that we don't allow these types of certifications, training programs to become true barriers to entry for people to these careers.
Right.
Yeah, totally get it. And I actually, the need to balance empathy, and understanding the population, right, or the patients that you're taking care of with. So I think you saying, Ashlee, that's key to, even if, have sort of that lived experience and that passion, and so there's a balance with that. But, a lot of states, federal government, CDC are expanding efforts to increase investment into community health workers because there's so much evidence around its effectiveness. And there's some comments as well in the chat around sustainability and around, where this investment ought to be. And one of the questions is about sufficient earnings. Some may be doing it with, because it's a passion, they want to volunteer for it. Is there any perspective that you would like to share? Because part of it is to disseminate to policymakers, and we may not always have the perception or the perspective of community health workers in our policy. So any thoughts about, the linkages you have to do and the earnings and how this can be sustained?
Yeah, maybe I'll let Ashlee jump in. But one of the things I can do, maybe I'll post to the chat. There's a brief that that Dr. Kangovi and others at the center worked on about career paths for community health workers that was published by Milbank. And so I'll post that in the chat. But it does relate to some qualitative work that they've done with community health workers to look into sort of career advancement and how does this become part of a career ladder. But Ashlee, do you want to jump in on that?
Far as funding, I'm actually working on a bill now with a few others, even with Dr. Kangovi, about getting sustainable funding for community health workers, because that's something that has been an issue. A lot of people have just been volunteering doing it, where you might be grant funded, but the grants run out. So that's something that we are working on for sustainable funding. It is an article that just came out like on the 14th. I'm going to try and find that in my email and post that in the chat for people to look at as well.
Awesome.
Yeah, I just think I'll speak to some of the economics of running programs is that when we started the program, it was about trying to find ways to advance some goals that the healthcare delivery system was trying to advance, while at the same time advancing goals that patients have. And is there a way to achieve some sort of financial sustainability? As everybody on this call knows, we've got this, these bizarre arrangements in healthcare of who saves money depending on what you're talking about. And so that's why, for instance, that ROI investment that I mentioned was from the perspective of a Medicaid payer, because as you can see from the outcomes of the trial, the big impact was from a healthcare utilization perspective and a cost perspective was on acute hospital care use. And so obviously payers have a big stake in that. And then thinking, as Ashlee just said, like, what does it look like to pay for these services and make them actually billable services in some way, because that is not how the landscape looks like today. And so most of what we're often trying to do is figure out how to create some sort of financially sustainable scenarios where you are advancing multiple goals at the same time that that the healthcare system or a payer is willing to be in. I think there's much more buy-in now than there was when we started this work, for sure, though.
Absolutely. And what about the future direction of the program? I mean, I think that's for you, for the impact program at Penn.
Yeah, so, again, this started as an effort that was all at Penn, and, Dr. Kangovi has really led an amazing amount of work to scale this across other states, other health systems, through payers. And so I think the latest that I heard from her is, working with about 50 different organizations across the country now, very broad geography. I think there's been a lot of work at the center to advance policy goals as well around some of the things that Ashlee has pointed out, with thinking about what's the right way to think about, credentialing, what's the right way to think about paying for these services, what is the right way to think about creating career ladders and opportunities. And so that's all been part of the work. I think that, but there's also just some really other amazing aspects of the program, like at Penn, for example. The center has created a mentoring program for executives in the health system, where the executives in the C-suite are being mentored by community health workers now, which really creates an opportunity to have very different conversations with those who are leading health systems. And I think that's an exciting thing that we've moved forward as well.
That's great. Awesome. Well, we're out of time, but there are lots of great questions in the chat, and hopefully we can go through and answer as much as we can. So I want to basically hand this over to my co-moderator. Love it. Yes. Dr. Jack Westphal, who is going to introduce our next set of speakers. Thank you.
Hi, this is Jack Westphal. It's such a pleasure to be here with you today, and I'm very excited to introduce Dr. Sonal Patil to discuss home blood pressure monitoring in cases of clinical uncertainty to differentiate appropriate inaction from therapeutic inertia. Dr. Patil is a clinician-investigator at the Wellness Prevention Medicine Department in the Cleveland Clinic Community Care Institute. She completed her residency at the Emory Family Medicine Program and worked as a full-time clinician at Kaiser in Georgia and East Boston Neighborhood Health Center. She chose to focus her research on health coach-led interventions after realizing the challenges of providing chronic disease self-management support in time-restricted, busy primary care practice visits. Dr. Patil transitioned to the Cleveland Clinic from Missouri because of the unique opportunities available at Cleveland Clinic with their well-established health coach programs and wellness resources. Please welcome Dr. Sonal Patil to discuss home blood pressure monitoring in cases of clinical uncertainty to differentiate appropriate inaction from therapeutic inertia.
Thank you, Dr. Westphal. Home blood pressure monitoring in cases of clinical uncertainty. This project was funded by American Academy of Family Physicians Joint Grants Award Program. Next slide, please. Thank you. So the background for this project is that white coat effect in treated hypertension is not associated with adverse long-term cardiovascular outcomes. Blood pressure is a physiologic parameter that fluctuates throughout the day. So the graph on this slide shows the blood pressure fluctuations in one person over a time period of 24 hours. In addition to the daily fluctuations, blood pressure fluctuates with physical conditions such as pain, infection, and emotions, positive as well as negative. Hence, rightfully, physicians and patients are reluctant to intensify treatment when they are uncertain if that single elevated clinic blood pressure truly reflects the patient's hypertension control state. Clinic blood pressures are known to be least accurate, and repeated out-of-office blood pressure measurements accurately reflect hypertension control state. Next slide, please. Thank you. However, physicians' hypertension control rates continue to be calculated and ranked based on the last documented single conventional clinic blood pressure measurement, which is rarely a research quality blood pressure measurement. So in a research setting, the patient rests for 5 minutes then the research staff takes blood pressure readings 3 times at 1 to 2 minute intervals. So the entire process takes somewhere between 10 to 12 minutes. And during this time, the patient is at rest, not talking, not completing any forms. Typical primary care visits are 15 to 20 minutes, and hypertension is infrequently the only reason for the primary care visit. So the clinic staff, in addition to checking the blood pressure, has to update medications, update immunizations, preventive health screenings. So the conventional blood pressure measurement is very distinct from the research quality blood pressure. But the hypertension guidelines, as well as the performance measures, are based on research quality blood pressure measurements. So we decided to look at a very simple question. When physicians and patients are uncertain about identifying treatment in presence of an elevated clinic blood pressure reading, will documenting average home blood pressures improve hypertension control rates and clinical decision making? Next slide, please. Thank you. So to answer this question, we recruited patients that had hypertension. Their recent clinic blood pressure was high, so they had uncontrolled hypertension based on clinic blood pressure measurement, and the physician did not change the medications at the current visit or in the prior 4 weeks. We loaned the patients with home blood pressure monitors and told them to check their blood pressure twice daily for 2 weeks. Proper home blood pressure measurement technique was taught and verified initially, and when the patient returned the home blood pressure machine using checklists. For outcomes, we looked at change in hypertension control rates when we substitute the clinic blood pressures with the average home blood pressures, physician responses to the average home blood pressure notifications. We surveyed patients for their opinions on home blood pressure monitoring, and then we conducted a chart review 6 months after participation to check if there were any subsequent clinic blood pressures and physician responses to those clinic blood pressures. Next slide, please. Thank you. So what did we find? 2/3 of patients with clinic blood pressure in uncontrolled hypertension range had controlled hypertension with average home blood pressure measurements. Of the 31 patients who continued to have uncontrolled hypertension based on average home blood pressure values, only 14 needed medication changes. So of all the recruited participants who had uncontrolled hypertension based on clinic blood pressure measurements, only 15% needed medication changes. Average home blood pressure documentation improved hypertension control rates. For example, substituting the average home blood pressure value for the last clinic blood pressure in 13 of the 278 hypertensive patients in one physician's panel improved that physician's hypertension control rates by 5%. When we looked at the 6-month chart review, there were at least 20 patients who had normal average home blood pressure measurements and a follow-up clinic blood pressure which was elevated in uncontrolled hypertension range. Physicians did not change medications in any of these patients. Next slide, please. Thank you. So in the participant survey responses to home blood pressure monitoring, several participants noted that because of the home blood pressure monitoring, they modified their health behaviors because they realized their diet, physical activity, as well as their stress levels affected the blood pressure, and modifying those health behaviors improved the blood pressure. Additionally, patients mentioned that they had an improved understanding of their hypertension control. So if the home blood pressure readings were normal, they felt reassured, well, it is normal, it's high only in medical settings. However, if the home blood pressure readings were high, they acknowledged that, well, my hypertension is truly not controlled, and they were more willing to add medications. When the patients were asked if they had any particular recommendations for clinical practices based on their participation in our study, 67% of patients said that the nurses did not follow the proper blood pressure measurement steps that they were required to follow when they participated in the study. So as one patient quoted, they should follow the same rules. The other common recommendation was that ask the patients to check their blood pressure at home for 2 weeks before or after the clinic visit and use that average to make clinical decisions. And again, as one patient quoted, have those of us affected bring in some kitchen readings. Next slide, please. Thank you. We could not predict the clinic blood pressure cutoff for which patients are more likely to have average home blood pressure reading less than 140/90. We looked at mild hypertension as a cutoff. We used the median blood pressure of all our recruited participants, but the same proportion of patients above and below these cutoffs had normal average home blood pressure reading. In fact, we had 16 patients who had systolic clinic blood pressure more than 170, and 10 of those patients had normal average home blood pressure readings. So in sum, hypertension guidelines and performance measures do not consider the impact of conventional clinic blood pressure measurements on blood pressure thresholds. Average home blood pressures should be used for estimating hypertension control rates and for clinical decision making. Next slide, please. Thank you. So from policy and practice implications, loaning or prescribing valid home BP monitors is important because non-validated home blood pressure monitors are common. In fact, a study looked at this, and 15% of the 3,000 commercially available blood pressure monitors are valid. All the others are invalid or inaccurate. AMA has a website, validatebp.org, which lists all the valid blood pressure monitors available in the US that can be used to make recommendations about home blood pressure monitors. Insurance coverage of valid home blood pressure machines may reduce disparities because 83% of patients who did not own blood pressure monitors said that they would buy one if insurance covered it. Team-based care can facilitate home blood pressure monitoring. You do not need a lot of home blood pressure readings. Just 3 days of twice daily home blood pressure readings are enough to estimate hypertension control. Increasing the duration to 7 days slightly improves the accuracy. Trust patients' self-report of home blood pressure reading if they own valid blood pressure monitors to improve patient engagement. Because several patients in our study told the research assistant when their home blood pressure came back normal that make sure you tell my PCP that this reading was normal, because I always tell her my home readings are normal. I don't think she trusts me. Trusting patients' self-report will encourage home blood pressure monitoring and their engagement in hypertension management. Electronic health records should have discrete extractable data fields for average home blood pressure entry. And if documented, that last recorded average home blood pressure value should be used for calculating hypertension control rates, irrespective of the follow-up clinic blood pressure readings. So this is something similar to hemoglobin A1C and a random glucose. If somebody has a normal hemoglobin A1C and 2 weeks later they have a random glucose of 300, we don't really change the diagnosis from controlled diabetes to uncontrolled diabetes. We should use average home blood pressure similarly when estimating hypertension control. Next slide, please. I would like to thank all my co-authors for their support and directions, with a special note of thanks to my research assistants, Noha Wareg, Kelvin Hodges, and Mark Kaiser. Thank you so much.
Wow, that was awesome, Dr. Patil. I really appreciate that. And we've had a number of questions, so I'm going to go to those. There were a couple people who asked about your decision to use 140/90 and how you came to that decision. Some recommend 130/80. So can you talk a little bit about how you made a decision to use particular cutoffs?
Okay, so the thing is, because we were trying to look at performance measures, none of the performance measures actually give a separate blood pressure threshold for home blood pressure monitoring and a separate threshold for clinic blood pressure monitoring. That was the first thing. And secondly, JNC 7 or 8, neither of those have any recommendations for like home blood pressure, like a separate blood pressure threshold for home blood pressure monitoring and office. We did actually look as an exploratory outcome even at that cutoff, and there were 40% of patients whose average home blood pressure readings were less than 135/85. However, when you actually look, that 135/85 or that 130/80 and that 140/90, all this is based on research quality and measurements, or like in research settings. When we actually did the study, there are patients who are in like moderate and severe hypertension range, and they have normal average home blood pressure values. So we thought really like reporting that 140 by 90 seemed to be more appropriate because again, our focus was on the performance measures and the inappropriate use of those clinic blood pressures for performance measures.
Thank you. In this study, did you document the brands? You talked a little bit about the validated and the not validated. Were you able to actually assure validated blood pressure cuffs for this study? And how did you record that?
Yes, so the thing is, when we did the study, the AMA list of validated blood pressure monitors was still not out, but there's another list of validated home blood pressure monitors. And then we actually used an Omron monitor, which was known to be validated. We checked the validation for it. And so that is how we made the decision. Essentially, the decision was made based on the cost and the ease of use for patients, because we wanted something that the patients could snap on, that they don't actually have to tie. And we tried to look at blood pressure machines that might give us some average of we could actually extract those readings in an Excel sheet format, like for our to extract the data. So those were the things that we considered. However, for home blood pressure monitors, you really don't need a fancy home blood pressure monitor, as long as it's valid and it can store 30 blood pressure readings, because you don't need a lot of blood pressure readings. And it should be able to tell you the blood pressure average for the last 14 readings with a push of button without having to sync it to some app or to some website. So any patient can just push it, look at the average and send that average to the PCP, or even if the patient brings the monitor, PCP can easily look at the average. I think those really are the basic things.
So Dr. Patil, a number of questions around rules and regulations. And historically, the quality metric has been the last reading or a reading in the practice, and you've described how those are not necessarily the best, and that may be average. However, there's lots of regulations around that don't allow that. And so the questions are, one is just flat out, how have you gotten around CMS regulations? Another is, how is NQF, the National Quality Forum, thinking about home blood pressure versus in-office blood pressure? I think the American Heart Association now recommends home blood pressure or ambulatory blood pressure readings. And so can you talk a little bit about sort of from a policy perspective, you have some great recommendations, but how do we convince, and what have you done to work with CMS and NQF to think about expanding their available data for this metric?
So we have not really done. So we tried to actually expand it in our clinic, and the clinic started using the average home blood pressure when they were calculating the physician's hypertension control rates. But we really have not reached out to Medicare or any other organizations. And this is where I'm hoping to make a case. Because, we have enough evidence that clinic blood pressures are the least accurate. So from a policy perspective or a performance measure perspective or a quality metric perspective, the question is, what are we trying to achieve? If we are trying to achieve better blood pressure hypertension control, or are we trying to reward performance? Either cases, you have to measure the blood pressure accurately, whether it's hypertension control or whether it's rewarding performance, because if you're not measuring the performance accurately, how are you going to actually reward the proper performance? So I really don't think that there is any argument left that we should not use average home blood pressures. And this is where I'm hoping to pitch it, that please allow this.
So Dr. Patil, you also have to teach patients how to take blood pressures. And so how do you do that? How I'm thinking about doing that in the busy flow of a practice versus working with our previous authors around utilizing community health workers to teach home blood pressure management. What are some ideas around making sure that patients understand how to take a blood pressure and take it accurately? And can you talk a little bit about that, please?
Yes. So when we designed the study, the way we designed this workflow is because we were trying to make a point, and we wanted the physicians to be absolutely sure that this reading is accurate, so you can act on this reading. But you really don't. So the in-person teaching takes around 10 minutes, and it's very difficult in a clinic setting. So we actually created a patient handout, which is a part of the appendix of our article, where we have the visualization, but we also have the information on why you need to follow each and every step. Because if you don't follow this particular step, your blood pressure is going to be high by this much number. And so once the grant was done, physicians used to give the blood pressure machine that handout, and then the patient would come 1 week later for a nurse visit and do it. The other options are actually, this is a very good way to engage the community in hypertension control, is because when you just tell them, okay, you eat right, you take your medications, you exercise, it's really difficult. But having that home blood pressure monitor adds an interactive component. So for example, I go to public high schools and we do a youth diabetes coaching program. We had a hypertension talk. We took some blood pressure monitors, and before the talk, we actually taught all the high school students how to use the blood pressure monitor, and then they checked each other's blood pressures, and that got them engaged in the talk. Similarly, once we went to a church that was having a chronic disease self-management class, and we taught the participants over there, that interactive component really helps. And I think the community-based education will increase the uptake of home blood pressure monitoring a bit more.
Awesome. Well, I think that is the questions that have been asked, and I'm hoping that people feel like their questions got answered. We have maybe time for one more question. And so I'm going to ask my co-host if she has a question, Dr. Irene Donkwa-Mullen, or if Ann Greiner, the head of the Primary Care Collaborative, who works with lots of primary care organizations, what she thinks might be effective to try to move the needle on home blood pressure across the primary care spectrum.
Irene, are you going first with your question?
I was going to have you go first. This is
well, thank you so much for this presentation. It is very, very interesting, and clearly work needs to be done to incorporate this new evidence into the performance measurement apparatus, including at the National Quality Forum. But beyond that, you know, we at the PCC are working to change how we pay and how much we pay primary care teams so that they can have more latitude and time to engage patients in this really important work, to do their own monitoring of their chronic condition and to be engaged in, you know, changing their behavior and the like to respond. So at a very high macro level, we really need to change the conditions under which primary care practices and teams are working to be more responsive to these clinical needs. So I'm bringing it way up a level, but I think it has such important implications for the work that you're doing. And so I wanted to just connect the dots there. Thank you so much. And I also want to give a shout out to PCORI, who is funding our Lunch and Learn series, because we think it's so important to be lifting up both these important clinical findings and the health services research findings to continue to evolve and strengthen the foundation of our health system, primary care. So thank you, Jack and Irene, for your leadership of Lunch and Learn. And I think Noah is going to close us out unless you have anything else that you'd like to say.
Great. So yeah, just wanted to say thank you again to our presenters, our two Lunch and Learn co-chairs for this great session. I wanted to ask that you please fill out a meeting evaluation. This is one way for us to get helpful feedback to improve the lunch and learns in the future and make sure that we're presenting the articles that you're most interested in. So please fill out that evaluation, and it is in the chat. And then the next Lunch and Learn is scheduled on April 21st from 11 to noon. And so we will be posting more information about that meeting in the coming months. So yeah, I think that's everything. And Anne, any final words?
There's been, thank you so much, Noah. And I really want to thank Noah for all of his hard work to help organize today's program. The slide decks will be available, as will the video of today's program, so you can share it with your colleagues. And we so appreciate this community's interest. It's exciting to see so many people turn out to learn more about the evidence base that undergirds primary care. So thank you again for joining us.
Thank you, everyone.